Thank you. Thank you so much, sir. So we'll leave that on if you would like.
I think it's better to leave it.
Better.
Is my voice clear?
Yes, sir.
Okay. You were wanting to show some video, isn't it? When you started, you said.
Yes.
Those were the marketing video to run. But then now we've got your screen sharing on, so we'll leave it that way.
Yeah.
Thank you.
I think another 2 minutes.
Another 2 minutes, yes.
Good evening, everyone. Today we are here for Prelude to Fetal Echocardiography Mastercourse. Let's welcome today's speaker, Dr. Pradeep Srinivasan, sir. Sir is the Director of Radiology and Fetal Medicine and Fetal Genetics at Fortis Hospital, Bangalore. Today, sir will discuss about cardiac biometry, how to do it. Without taking more time, I hand over the session to Dr. Pradeep, sir. Over to you, sir.
Thank you.
Welcome, Dr. Pradeep. Thank you so much for coming over and honoring us with your great knowledge and immense learning. Thank you so much, Dr. Pradeep.
Thank you very much, Dr. Alka, for giving me this opportunity. I hope the listeners will be immensely benefited by this lecture. Let's go into cardiac biometry. A very good evening to everybody who's on board. So we will be looking at cardiac biometry as a topic today. Actually, cardiac biometry comes much later after one learns to understand how to do the routine imaging and how to do the measurements. And biometry is something which comes much after everything. But as a prelude to the long fetal echo course which we have planned, we thought that the listeners should understand what is in store for them in future, which is very important for them to know. So that's why among all the topics in fetal echo, we decided to do the cardiac biometry to give a sample of where one should head at the end of this course, what one should be able to do at the end of this course. So that's why we chose the topic cardiac biometry. Now, to give you an example of what is biometry and how important it is, and what is the relevance to us, I've put this slide up. So we all know that Raymond's has been stitching suits for men for generations together. And their adage says that a complete man is one who has a perfect fit, right? And how does one get a perfect fit? A perfect fit is always tailor-made. And when we say it's tailor-made, it is measured and made. So for a perfect fit to become a complete man, we need measurements. And that's what all is about in cardiac biometry. It's all about relevant measurements, which would make a fetal echo a complete fetal echo. Okay, so that's why I put up this adage so that we understand what is the importance of a cardiac biometry, which would mean simply fetal echo with relevant measurements. So when we want to do a fetal echo, one would like to embark on a journey where the fetal echo would be complete when he does it. So a complete fetal echo is one where there is a perfect diagnosis. For example, I have shown a pic here, which is a color Doppler of a 4-chamber view. And you can see that on the right heart, as the blood is entering from the atria, which is below, into ventricles, which are above, the color is red. Okay, so the inflow across the atrioventricular valves is in red. At the same time, you can see that there is a bright blue hue right on the tricuspid valve here on the color Doppler. So when one recognizes that there is a reversal of flow as evident by the opposite color at this anatomical location, which is the tricuspid valve, one knows that there is a regurgitation. So when we tell there is a regurgitation, there is a method of improvising on it. And that improvisation happens by doing a Doppler. So we apply a Doppler here, we open out the sample box, we acquire the flow information across the tricuspid valve, which gives us a tricuspid Doppler as shown here. In this tricuspid Doppler, we have a forward flow, which I will be explaining to you later. And also we have a reversed flow, which is of a higher velocity. So this reversed flow is the flow at this location. And now we are not only able to prove that there is a reversed flow using Doppler, we will be able to quantify the amount of reversed flow. We will be able to quantify the speed of the reversed flow, which indirectly is derived from the velocity of the peak limit of this reversed flow. This is a very simple example of how to quantify the qualitative findings of the fetal echo. So a measurement and a quantification in order to understand the severity of the color Doppler findings is called as fetal cardiac biometry. And using these curves and measurements, analysis becomes much better, because when we follow up these cases, we will have a value to compare with, and according to the change in value, which could be higher or lower, prognostication of a condition is possible in a much intelligent manner rather than roughly telling there was a tricuspid regurgitation, it is still there, I am not sure whether it is bigger or smaller. Now, by using Dopplers and by using these measurements, we are much intelligent by telling that there was a regurgitation. Now we have a regurgitation yet persisting. It was of such velocity and now it is of a different velocity. And using these, we can actually tell them whether the condition is becoming better or worse, and we can prognosticate. So with this small introduction, we will go into various features of cardiac biometry. So the first question asked is, what is cardiac biometry? Just like how we do biometry in various parts of the fetal body, we do biometry in parts of the heart. So in very simple terms, quantification of 2D analysis is called as cardiac biometry. So why is cardiac biometry required? It is required for better understanding of variations in size of the cardiac anatomy, variations in flow velocities, variations in volumes, variations in rhythm, etc. So we better understand all the variations in these parameters when we do fetal echo. So why is it required? It is required for prognosticating cardiac conditions. When should cardiac biometry be done? Routinely, we do not need to do cardiac biometry for every patient. So when we have 2D abnormalities, when we have color Doppler abnormalities, then we should bring in cardiac biometry into the picture. But having said that, a few of these measurements have today become routine measurements during our TIFA scan. Forget fetal echo. Even in a routine TIFA scan, we are supposed to see few fundamental basic structures and information like the sizes of the chambers, the sizes of the outlets, which would be the aorta and pulmonary artery. So one could do such basic measurements during a routine TIFA scan, and we can escalate into an advanced cardiac biometry when we encounter 2D anomalies or color Doppler abnormalities. So now the question comes as, we are going to measure. So what are the measurements that we are going to do during the cardiac biometry? So there are a list of measurements here. So one could measure the annulus sizes of the aorta and pulmonary artery, the LVOT size, the aortic arch size, the aortic isthmus size, the RVOT size, the branch pulmonary artery sizes, the chamber sizes in systole and in diastole. Then one could go on into Dopplers, perform a mitral Doppler, a tricuspid Doppler, which are inlet Dopplers. Then one could do an LVOT Doppler, an RVOT Doppler, which are outlet Dopplers. And then we can move on to certain advanced Dopplers like the mitral aortic Doppler or the aortic SVC Doppler. And finally, we can perform the M mode like how we do in the adults. So there are a large number of measurements, ratios, etc., which can be done during a cardiac biometry. We will look at that one by one as long as time permits today. And then if the time doesn't permit, it will go into a detailed discussion during one of the courses which come under the heading of this biometry. Now we decided that we are going to measure. What are the measurements, methods by which we are going to measure? We can do measurements on simple 2D black and white views, on M mode views, and on Doppler waveforms. So these are the three ways in which measurements can be acquired during a cardiac biometry. So first, let us look at measurements which can be done during the 2D analysis. So from the 2D pictures which we have acquired, which one has learned during acquisition of normal cardiac views, we can measure the left ventricular outflow tract, the right ventricular outflow tract, and the chamber dimensions. So these are examples of 2D measurements. Once we do the Dopplers across the semilunar valves, across the atrioventricular valves, across the inflow-outflow, which is the iotomitral Doppler, we can do various measurements on these Dopplers. Also, we can do Dopplers on the ductus arteriosus, ductus venosus, the IVC-SVC pulmonary veins, on which we also can do Doppler measurements. So these are all various locations where we can acquire Dopplers and do the measurements. Now coming to the M mode, an M mode is acquired by a continuous wave Doppler line which goes either from RV, interventricular septum, and LV, which is on a lateral four-chamber view, or across atrium, AV valve, and ventricle, which is on a four-chamber view. So these M modes can be used for various measurements. We will look at all the pictures as we go forward. So now we have our classical four-chamber view, which is shown here. Now we have the apex pointing up, the base pointing away. Then this is the aorta, which is on the left side. That's the right side. We have the left atrium, the right atrium, the left ventricle, and right ventricle. So after we have acquired a four-chamber view in a symmetric manner with the proper zoom and visibility, one could start simple 2D measurements on these chambers. After the four-chamber view, we rotate the probe into a mid-sagittal plane when we get the right ventricular outflow tract as shown here. That's the RV, that's the PA, and here we have beyond the pulmonary valve, the main pulmonary artery. And that's how a 2D measurement of the pulmonary artery can be done, which is done from the inner to inner wall of the pulmonary artery. When the pulmonary artery is in diastole, that means when it is open widely. This is the LVOT view, where we have the aorta in view in its long axis, and that's the aortic valve, and this is the annulus region, and we can do the measurements as shown here. Similarly, when we get the branch pulmonary artery views, we can measure the right branch pulmonary artery, left branch pulmonary artery as dimensions. That's the aortic arch view, where one can measure the ascending aorta, arch of aorta, isthmus, and descending aorta. That's the three-vessel view, where one can measure the pulmonary artery, the aorta, and SVC. Now let's say that we have learned to measure all these in the right plane after we have acquired the right 2D images. What do we do with these measurements? Automatically, these measurements have to be plotted on Z-score curves as shown here. Like how we plot the BPD, HCAC, and FL on our growth charts, these measurements which we have done get automatically plotted on Z-score graphs. So these are the Z-score graphs. On the x-axis, we have the gestational age running from 15 weeks to 40 weeks here. on the y-axis, we have the sizes in millimeters. Now let's say we have done the fetal echo at the 20th week. You can see here this is the 20th week and there is a red dot. Now this is the right ventricular size in diastole, which is about 7 millimeters as shown on the y-axis. So this 7 millimeters done on the right ventricle as its diameter at the 20th week has fallen at this location. Now if you extrapolate this location, and it is the third line from above. The third line from above gets a score of 1. And our red dot of the fetus has fallen just below the 1 mark. It is between an Z score of 0 and an Z score of 1, which would probably have is score of plus 0.8. Similarly, you can see the left ventricle has fallen on a Z score of close to minus 0.4. The pulmonary artery has fallen on a Z score of approximately plus 0.8, and the aorta has fallen on a Z score of minus 0.5. So what do these mean? These mean that at the 20th week, the size of the pulmonary artery, aorta, right ventricle, and left ventricle are all around a Z score of 0, within a score of 1 and minus 1. Hence, this is a normal sized RV, LV, PA, and iota. So that's the inference we get from the Z scores. Now, when the measurement falls much away on a Z score of 2 or much below on a Z score of minus 2 or minus 2.5, we understand that the chamber size is either very large or either very small. So by these Z scores, we have quantified the chamber size or the vessel in question size, and this quantification has allowed us to tell whether the alteration in the chamber size or the blood vessel size is mild, moderate, or severe. And using the Z score, when the patient comes back again for a scan, we would know whether there is an improvement in the size or whether there is a deterioration in size, which would help us prognosticate. So that's how measurements get interpolated into scores, and scores give a meaning to the variation of these measurements. Similarly, we have M-mode measurements. So in the M-mode, the cursor can be parallel to the interventricular septum through the atrium, AV valve, and ventricle, and we get a graph. From the M mode, we can get the atrial heart rate, the ventricular heart rate, the dimensions of chambers, the thickness of the wall of the chambers, the thickness of the interventricular septum. Not only we get the measurements during systole, we also get them during diastole, because M mode is a continuous trace over a period of time at a particular location. So here we have an M mode cursor going across the LV, the interventricular septum, the RV on a lateral 4-chamber view. Now this line has intersected this type of anatomy over a continuous period of time where the heart is contracting and relaxing. Hence, we get a mobile type of wavy echoes on the M mode, which vary as the heart contracts, relaxes, contracts, and relaxes. Similarly, you can see the wall thickness also shortens, widens, shortens, widens along the contraction and relaxation of the heart. So by using this M mode, we can measure the wall thickness, the chamber size, the septal thickness, the far chamber size, the far chamber wall size. And this size is continuously changing during the systole and diastole. So the changes in the thickness of the wall and septum and the changes in diameter of the chambers are measured. And using these measurements, a large number of calculations can be done. Coming back to Doppler. We all know how Dopplers function, and the simplest measurement on a Doppler analysis is the velocity, peak systolic or peak or end diastolic. That is a velocity. So one can do Doppler measurements on the left ventricular outflow tract, right ventricular outflow tract, isthmus, mitral valve, tricuspid valve, ductus arteriosus, ductus venosus, IVC, pulmonary veins, foramen vein. So in multiple locations, we can do angle-corrected Doppler measurements. Now we will look at one by one these Doppler measurements. Now this is a very classical ductus venosus measurement, which most of us do during our third trimester growth scans as a part of the Dopplers which we do. Hence, I selected this as a first Doppler. Now, the ductus venosus, you all know, connects the umbilical vein with the IVC and is a trumpet-shaped organ which facilitates the oxygenated blood from the umbilical vein to go across the foramen ovale from RA to LA in order to bypass the pulmonary circulation. Okay, so the ductus venosus waveform is classical. It has an S wave, a D wave, and an A wave, and there is no reversal of A wave in the ductus venosus. So the characteristic point of a ductus venosus is it has always a forward flow irrespective of the cardiac cycle. So with these waves, we can get an S by A ratio, an S by D ratio, an S minus A by S ratio. So many times the waveforms have a lot of measurements to be done, and from the measurements, ratios can be arrived, and from the ratios, a meaningful assessment of the waveform and the flow can be assessed. Now this is a IVC Doppler. So now you can see that the IVC is a structure behind the right atrium, and hence the pressures of the right atrium are reflected on the IVC. It's a soft, pliable structure, unlike the ductus venosus. Hence, when the atrium contracts, there is a wave reversal. So this is S, D, and A. And in the IVC waveform, there is normally an A wave reversal, because when the atrium contracts, the pressure is transmitted into the IVC, which yields and has a small reversal. So what is not there in ductus venosus as an A wave reversal, which could be pathological, is always there in an IVC, SVC, or pulmonary vein, which is physiological. So that is a fundamental difference one has to learn. This is a pulmonary vein Doppler, which is behind the left heart, left atrium, and that receives the pressure of the atrium when it contracts as an A wave reversal. So the SVC, IVC, and pulmonary veins have normal physiological A wave reversal. Moving into the heart, for the atrioventricular Dopplers, the sample box location is as shown here. It is kept at the place of the coaptation of the valves, and the sample box is opened out so that part of it is in the ventricle and part of it is in the atrium as shown here. So thereby, if there is a regurgitation, it will not be missed. So keep the sample box across the valve, angle correct it across the flow direction, open the sample box to 2 millimeters or 3 millimeters so that it is able to get flows from the part of the flow beyond proximal to the valve and part of the flow distal to the valve. So that's how a Doppler is placed on an AV valve. Once we place it on the tricuspid valve, we acquire a tricuspid Doppler waveform as shown here. The tricuspid and the mitral have similar type of waveforms. They have two peaks. One is E and one is A. We will look at the meanings of these peaks as we go forward. So remember, the atrioventricular valve has bimodal peak, and the first peak, which is shorter, is called as the E wave. Second peak, which is taller, is called as the A wave. For now, just remember this. We will go forward. Similarly, the mitral valve has E wave and A wave, exactly like the tricuspid valve. So these are two pictures of tricuspid and mitral. So if we do not see the picture above, we will not be able to say whether this is mitral or this is tricuspid. So both the atrioventricular valves have two peaks, one short, one tall. The first is E, the second is A. Coming to the outlet Dopplers, when we do the pulmonary artery Doppler, we get the RVOT outflow view. We identify the pulmonary valve. We keep the sample box immediately distal to the pulmonary artery, angle correct, and then get the waveform. Unlike inflow Dopplers, the outflow Doppler has a single peak with a sharp rise and a gradual fall. And coming to aortic Doppler, that's the LVOT view. This is the aortic valve location. This is the systole, so that's why the valve is not seen. And the sample box is kept just distal to the aortic valve. And again, we get a sharp, fast upthrust and a gradual fall, which is a single peak of the semilunar outlet valves. Now I'm going to introduce to you what is aortomitral Doppler. Now, when we learn the technique of doing fetal echo, when we talk about 4-chamber, 5-chamber, 3-vessel, etc., it is the 5-chamber view or it is the LVOT view where we can do this aortomitral Doppler. What are we trying to do here? Mitral Doppler is a Doppler which gives us the atrial events. And aortic Doppler is a Doppler which gives us meaning and information about the ventricular events. Now, when we want both events together in order to derive a lot of information, it is possible only on the left heart because anatomically the mitral valve is continuous with the aortic valve. This I will teach you when we look at the LVOT view, where we will be talking about each part of this anatomy, when you will realize that the mitral valve and aortic valve are continuous anatomically. This is not true in the right heart, where the tricuspid valve and the pulmonary valve are separated and not continuous. We take advantage of this continuous anatomy and we open out the sample box and we keep the sample box in this location. Now this is the interventricular septum. That's the anterior wall of aorta. This is the mitral valve. That's the posterior wall of aorta. This is the aortic valve. This is the aortomitral continuity. You need to keep the sample box here. Open the sample box to 3 millimeters or so that the Doppler will catch not only blood flowing from LA to LV, but also blood flowing from LV to aorta. So it will catch the Doppler information of inflow and outflow, and that will be shown as aortomitral Doppler, which I will show as we go forward. This is the location for aortic isthmus, and this is the characteristic aortic isthmus Doppler. This is the pulmonary artery Doppler. This is the ductus arteriosus Doppler. So these are to show that Dopplers can be done at various locations as required, and that's the aortic arch view. And you can see that the subclavian artery is shown here, and immediately distal to the subclavian artery is the aortic isthmus. And that's where the Doppler sample has been placed with the angle correction along the flow, and aortic isthmus Doppler becomes important in third trimester, unlike in fetal echo for cardiac anomalies. Ductus venosus is a structure which is a continuation of the umbilical vein and connection between the umbilical vein and the IVC. So that's the ductus venosus, which is a small trumpet-shaped organ, narrow proximally, wide distally, with an aliased color, and that's where we keep the sample box to get the ductus venosus waveform. This is a early fetus, and this is a slightly larger fetus. This is the ductus arteriosus flow. The ductus arteriosus is the artery with the highest velocity among all the cardiac structures. So it is a very, very high velocity organ. Now, quickly about the chamber sizes. That's the 4-chamber view. This is LV-RV, and this is the cardiac diastole when the chamber sizes are in their maximum. These are the AV valves. Just below the AV valves, we take the chamber sizes from inner to inner wall at the diastole, which will give us the maximum size of the left ventricle and right ventricle during the diastole. So that's another example showing the maximum dimension of the RV and LV from the interventricular septum to the free wall, taking a measurement from the inner to inner wall. We take inner to inner wall because when we do M mode, the chamber which is void of tissue comes on M mode as a dark structure. That is why we take from inner to inner, because in M mode, we will be again measuring from inner to inner. This is the atria during diastole. So it will be wrong to take all the 4 measurements in a single 4-chamber view. The reason is, if the ventricle is contracting, the atria would be relaxed. If the atria is contracting, the ventricle would be relaxed. So if you want atrial diastole, it will be in a separate picture. If you want ventricular diastole, it will be in a separate picture. So measurements have to be made by scrolling the cine loop, and by looking at the atrial diastole and by looking at the ventricular diastole, measurements can be made on the relevant pictures where the cardiac sizes are in their maximum. If you want systole, then scroll the picture, and once the ventricles contract, then you can do the systolic measurements. These are better done in M mode. That's the RVOT view, and that's the 2D dimension of the RV. That's the LVOT view, and that's the 2D dimension of the LVOT. Also, one could measure the atrioventricular valve size during the atrial systole. So we know that the atrioventricular valves co-opt and open. When they are completely open, the valve disappears, and then we are able to measure the annulus of the tricuspid valve. So that's the tricuspid valve which is open completely during the atrial systole, and that's the measurement of the tricuspid annulus. So these are helpful when we have disorders of tricuspid atresia, tricuspid stenosis, tricuspid dysplasia, etc. So that's the inflow and that's the outflow. Inflow is bimodal, outflow as a single peak. Now we are going to come to a very, very important slide, which I will spend at least the next 10 to 15 minutes. This is the cardiac chamber picture where we have the hemodynamics of the heart. We will use this to explain these waveforms. I have drawn the ECG on the top, the mitral waveform here, aortic waveform here. This is the mitral aortic Doppler, which we just studied as how to obtain. This is the IVC Doppler, which we just saw with the normal reversal. This is the pulmonary vein Doppler, which we saw with the normal reversal. This is the ductus venosus Doppler, which we saw without any reversal. So we have ECG, aortomitral Doppler, IVC Doppler, pulmonary vein Doppler, ductus venosus Doppler. Now, the aortomitral Doppler talks about atrioventricular dynamics, ventriculo-arterial dynamics of flow. The IVC pulmonary veins talk about the pressures transmitted behind the heart, that is, on the venous side of the heart. An extension of venous side of the heart on the right side is the ductus venosus Doppler. These are the Dopplers which are going to be very important when one has cardiac failure and one is trying to analyze cardiac failure assessments. Now you can see that I have kept one below the other and I have drawn certain vertical lines. So these vertical lines have divided the flow across these organs or chambers into multiple phases. These are the phases of cardiac cycle, these vertical lines. Let us come to ECG. That's the P wave, Q wave, R wave, S wave, T wave. There is a gap. Again, a P wave starts and we have QRS complex. Going back to our MBBS knowledge, P wave stands for atrial contraction. QRS complex stands for ventricular contraction. T wave is the end of ventricular contraction and there is a pause and again the atrial event starts. We need to understand each waveform in relation to ECG, in relation to cardiac events. It may sound complex, but it's actually very, very simple. If we understand each waveform and the cardiac cycle in which the waveform is generated, it becomes extremely simple. We will look at it one by one. Now, first, the veins bring blood into the atrium. So the LA fills up, the RA fills up. Let's take the example of LA. Now the LA fills up and it has to empty into LV. So when the LA is full, the mitral valve opens. The moment the mitral valve opens, blood flows from LA to LV passively. Then the atrium tries to empty everything into the ventricle. So it contracts actively. So this is the events which go across the mitral valve. First, there is passive flow across the mitral valve from LA to LV. Then there is atrial contraction and there is active flow from LA to LV across mitral valve. We have done a mitral Doppler. How does this look on Doppler? So the passive flow is the first peak, which is shorter, which is called E wave. Then the atrium contracts and the active flow is the taller peak, which is the A wave. So that is how we get a bimodal EA waveform of the mitral valve. Is that understood? So the passive flow from atrium to ventricle is E wave, and the active flow from atrium to ventricle is the A wave. Then that corresponds to P wave of the ECG. Now the atrium is empty, ventricle is full, the mitral valve closes. The full ventricle now has to empty into the aorta, and the aortic valve will open. After the mitral valve closes, before the aortic valve opens, there is a pause. That pause is this gap. Okay. Then the aortic valve opens and the ventricle, which is a muscular organ, contracts and pushes the entire blood out in one stroke. That is the V wave or S wave of the ventricle. So this is the next phase. The ventricle empties fully, aortic valve closes. Meanwhile, the atrium has filled up. Now the aortic valve will close and the mitral valve will open. After the closure of aortic valve, before the opening of mitral valve, there is another pause. That is this phase of cardiac cycle. Then the mitral valve opens, then the E wave comes and the A wave comes. So now we have understood the cardiac cycle has an E wave, an A wave, a pause, an S wave, a pause, an E wave, and an A wave. So these are the phases of cardiac cycle, and these phases are phase 1, early diastolic filling, phase 2, atrial systole, phase 3, this gap, which is called as isovolumetric contraction, phase 4, ejection time, phase 5, this gap, which is the isovolumetric relaxation. So now this complex looking thing has been simplified into multiple cardiac phases. I repeat, early diastolic filling phase, atrial systole phase, isovolumetric contraction phase, ejection time or phase, isovolumetric relaxation phase, and again the cardiac cycle goes to atrial filling phase, atrial systole phase, isovolumetric contraction phase, and so on. If you have understood this, now you will realize what is happening behind the heart. Behind the heart, when the ventricle is pumping blood out, the atrium has to fill. So when the atrium has to fill, there is flow from IVC and SVC into atrium. So the ventricular systole S wave will correspond to the S and D waves of forward flow in the IVC and in the pulmonary veins and in the ductus venosus. So when the heart is emptying out, there is forward flows on the veins behind the heart, filling the atrium. So that is why on the venous Dopplers, we have forward flow, which corresponds to the ventricular ejection. Now, when the ventricle is filling, that is when the atrium is contracting, what happens? The pressure falls back on the SVC, IVC, and pulmonary veins, and that is the A wave reversal in the venous side. So here we have the atrium contracting, that is the atrial systole of the mitral valve, and that systole causes a reversal of flow in the IVC and pulmonary veins because these are soft structures. The same atrial systole is not able to cause a reversal of flow on the ductus venosus because it is a muscular organ. Now imagine that if the atrial systole is able to cause a reversed flow in ductus venosus, then the systole or atrial contraction should be extremely strong. When is it going to be extremely strong? When it is not able to pump into the ventricle. When is it not being able to pump into ventricle? When the ventricle is failing. So in cardiac failure, when the myocardium does not yield, when the ventricular pressure is high, the atrium struggles to push blood into ventricle. And that struggle of the atrium will be a strong A wave. And that strong A wave will cause initially a depression in the ductus venosus A wave. Then it will cause an absence of A wave. Then it will cause a reversal of A wave, which is what we see during hypoxia, late hypoxia, acidosis, and near fatal death due to ventricular failure. So that's how strongly these waveforms and their measurements and their understandings interpolate into cardiac function. So acquiring a waveform is not doing a fetal echo. Understanding the waveform and interpreting the waveform and analyzing the changes in waveform and applying it on a heart which is failing will be able to tell us what is the type of failure and after treatment whether the things have improved or not. So this one picture with the 5 waveforms will make one understand multiple cardiac phases and atrioventricular Dopplers and ventriculoarterial Doppler and the transmission of the cardiac pressures into the veins especially ductus venosus, which talks a great deal about cardiac failure, which we apply during our growth scans. I hope I have made this cardiac cycles easy with this line diagrams. So I have a YouTube video on this. If you're interested, just go to Dr. Pradeep Srinivasan's YouTube. Just type cardiac cycles or phases and you will get this. Listen to it. It's the same repetition, but it's great to understand these waveforms. And tomorrow, when you do your mitral Doppler, you will perfectly understand what is the first wave, what is the second wave, what is the third wave, what gave rise to the wave, why is this short, why is that tall, and if it alters, we will be learning about alterations in a great deal when we look at pathology. Welcome. I think Dr. Alka is.
Thank you so much.
Okay,
that was fantastic.
Yeah.
Thank you so much. That was fantastic. Very detailed. So we do have 6 questions in the chat right now.
Yeah.
So I'll take up them.
Yeah.
The first question is, please advise how best to do echo for a beginner on a basic machine Varsana Essential GE.
Okay. In today's scenario, even entry-level equipment have the capability to show cardiac chambers very clearly and have the capability to do Dopplers very clearly. Since one is embarking on beginning of doing fetal echo, what we spoke now is not what I expect you to do at all. That's why I told you in the beginning, we've taken up an advanced topic so that you understand that you need to reach here. Do not get disheartened. The answer to your question is, your aim in doing fetal echo is not to miss a complex cardiac anomaly and to understand to refer it off for a second opinion. It is okay if you miss a small VST or a small AST, but it is not okay to miss a double outlet right ventricle or to miss a transposition of great vessels, because that is the only chance the fetus gave you. So the idea of learning fetal echo is not to miss a complex anomaly. And yes, you can do with the basic GE machine, a routine fetal echo. It may be difficult to get great color pictures and shunts, but it will not at all be difficult to get the basic anatomy in order not to miss veno-atrial concordance, atrioventricular concordance, ventricular-atrial concordance, large AST, large VST, TAPVC, and hypoplastic left heart, hypoplastic right heart. So this is what is expected of you. And yes, you can do it with your machine.
Thank you so much. So the next question is, sir, where do I find these Z-score charts?
Yeah. Whoever is your application specialist, call him to visit you. Tell him to go to settings. Most equipment have the Z-scores. It will be off. We have to go to settings and enable the Z-scores and link to the measurement. So if you're going to do RV size, do not just measure it. Like how we select a BPD button and then measure BPD so that the measurement goes and sits there. You have to go to fetal echo measurements, select the RV, then do the measurement. And if you have enabled the Z-score charts, your measurement will say 5 millimeters for 18 weeks, a Z-score of 1.1. That is how it should come on the bottom of the page. So you need to get that enabled, which is possible in every machine today.
Thank you so much. Good to know. And next is, what is abnormal Z-score?
So when we have a variation in size, which is increase or decrease, it becomes an abnormal Z-score. A perfect Z-score is one where the score is around 0 up to +1 or -1. Any deviation of more than 1 or +1 or -1 would start becoming abnormal.
Thank you. Next is, what is the difference between ventricular discordance and hypoplasia, either right or left?
Okay. I think your question should be, what is atrioventricular discordance?
Yes.
Because when there is a difference in connection between the expected atrium and ventricle, it becomes a discordance. When the size is small, it becomes hypoplasia. Both are completely different.
Thank you. What is the significance of aortomitral Doppler?
It is the most powerful Doppler in understanding cardiac events. When you come on the lecture, this aortomitral Doppler will be used to measure atrial heart rate, ventricular heart rate, to look at conduction disorders, to look at atrioventricular time, ventricular-arterial time, to look at myocardial performance index. So many measurements are possible with this one Doppler done across the aortomitral continuity. And with these measurements, a large number of derivations can be made. That is the significance of aortomitral Doppler. To put it in a very simple way, conduction disorders are possible to be analyzed with the aortomitral Doppler, AV conduction disorders.
Thank you. Next is measuring in diastole for LV and RV. The AV valves should be open, but in your image it was closed.
Okay. The images which I showed all may not be perfect, but when we measure, the AV valve will be open, which is why I said you scroll your picture, wait for it to open out, then do the measure.
Thank you. Next, how to measure CT ratio?
Cardiothoracic ratio.
Cardiothoracic ratio.
You take an axial section of the thorax in a perfect axial way, measure the lateral to lateral ends of the heart at the level of the crux on its widest dimension, measure the inner to inner dimension or diameter of the chest on a coronal plane in the mid part of the chest, and the ratio between these two measurements is the cardiothoracic ratio.
Thank you so much. Next is, as a beginner, I do 4-chamber RVOT, LVOT, 3-vessel and 5-vessel view. What more needs to be done? Excellent.
The only thing you need to complete it with a 3-vessel tracheal view, which will show you the confluence of the ductus arteriosus and the aortic arch. So do your 4-chamber, come into 5-chamber, get the great vessel crisscross, get your 3-vessel, end with the 3-vessel tracheal view, wherein you can show a left-sided aortic arch and a confluence. So please do that last bit, and then the RVOT, LVOT, you're done with ruling out 85 to 90% of anomalies.
Thank you. Next, kindly comment on coarctation COA with regard to ventricular discordance.
See, coarctation of aorta is a separate entity which does not require a discordance. I think what you're trying to mean is chamber size. Okay, I got what you're asking. When we have an isolated left ventricular smallness with everything else okay, and also a associated aortic smallness or LVOT smallness, we infer an evolving coarctation. We may not be able to show a coarctation or narrowing at the isthmus or a shelf or a jet. So, in a routine analysis of the heart, when the left-sided heart is smaller than the right side, not significantly but mildly, and when the aorta is also smaller as compared to the pulmonary artery, there is a ratio between the PA and aorta. When this ratio is widened, we need to suspect an evolving coarctation. So a smallness of the left heart without any other anomaly is a marker for evolving coarctation of aorta.
Thank you. Next is ventricular thickness. In which cycle is it to be measured, especially to see in diabetic mothers?
Usually it is best to do the M mode and then take the ventricular diastole thickness, and we have normograms to look at the ventricular thickness. So the interventricular septum can also be measured in 2D, and the far lateral four-chamber view in ventricular diastole, where the interventricular septum becomes its thickest, is the measurement to be done, best measured in a mode.
Thank you. So where to measure it? I think that's all covered. Next is, please tell advantages of attending this complete course.
Okay. Fetal echo is not a separate test. It is part of a routine anomaly scan. You cannot tell that I did not diagnose cardiac anomaly because I did not do fetal echo. In the court of law and in the court of consciousness, cardiac anomaly rule out is part of basic rights and duties of us. So we need to be aware of fetal echo. That's how simple I can put it.
Absolutely.
By attending the course, you will become more confident. You will understand things better. You will be able to see multiple anomalies, which you will take at least 10 years in your lifetime to see. So the next time when you see something, you will already know about it. The simple adage, what the mind doesn't know, the eye doesn't see, can be erased by learning more.
Okay. Thank you so much. That was wonderful. So, sir, when to comment on pericardial effusion?
A small pericardial effusion is physiological.
Okay.
I see it routinely with beautiful equipment which we have and with the fetal echo settings which we have. Demonstrating fluid around the heart is very, very common. Then how do we differentiate? An effusion which is more than 2 to 3 millimeters in diameter, an effusion which crosses the crux and goes from one half of the heart to another half of the heart, an effusion which is on either sides of the heart, an effusion which has internal echoes, can be considered abnormal.
Thank you. Next is, more questions are being added. So how to perform MPI?
I need another half an hour for that, but I'll quickly put it to you.
Okay.
From the atrioventricular Doppler, which we just learned, I told you that there are two phases called isovolumetric contraction, isovolumetric relaxation on either sides of the ejection time. Isovolumetric contraction plus isovolumetric relaxation divided by ejection time is MPI.
Thank you. Next is last four more questions. When all anomalies can we miss? What all anomalies can we miss if we are doing basic all four views, 4CV, 3VV, 3VT, RVOT, and LVOT?
Okay. There are multiple anomalies which can be missed by doing advanced fetal echo also. For example, branch pulmonary artery anomalies, coronary artery anomalies, all pulmonary venous anomalies, extremely small ASTs, sinus venosus defect, extremely small VSTs, and so on and so forth can be missed. If you do not do your outlets, just by doing four-chamber, you will miss 50% of anomalies. By adding four-chamber, three-vessel tracheal, you will miss only 10 to 15% of anomalies. By completing it with RVOT, LVOT, arch ductal arch, aortic arch, hammock view, and a little more extended views, and by doing color Doppler and picking up regurgitations, etc., almost 95% of anomalies can be picked up. The 5% nobody can pick up, like what I said, a small coact, a small AST, a small VST, coronary anomalies, certain fistulas, branch pulmonary artery, branch pulmonary vein anomalies are difficult to pick up.
Thank you. So next is, what is the importance of cardiac evaluation in third trimester?
Extremely important when you miss something in your first and second trimester. The fetus is giving you a last chance, trying to tell that, look, I'm here. Why don't you diagnose me? So I know how difficult it is during a third trimester to look at the heart, but at least when you're taking the cardiac rate, do it at the tricuspid value. The more chances of picking a regurgitation. When you're doing the heart, just at least, even if it is oblique, twisted, torted, make sure there are 4 chambers at least of equal size, and just move up and see that there are 3 vessels. This much, if you do, around 75 to 80% of times, major anomalies will not be missed. That is one part of it as far as anomal structure is concerned. Second thing is, it will be useful to do all these things only when there is hypoxia and acidosis, when the heart is failing. But we have such robust umbilical artery, ductus venosus, and other measurements that rarely we need to go into the heart and again extrapolate and show that the E by A wave is altering, the myocardial perfusion index, performance index is altering. Not required to go into the heart and show the same. But yes, if you have an acidotic fetus, by showing an A wave reversal in the ductus venosus, or by showing a high resistance or absent diastolic flow in the umbilical artery, where did it come from? It has obviously come from the heart. So you go to the heart, you will find the proof there. Don't need to do it.
Thank you so much. And thank you for your dedication and patience as well. Beautifully answered. So please tell about cardiac hypertrophy. Do we need to measure cardiac wall thickness?
Yes, when we look at HOCM, when you're looking at cardiomyopathies, these are very advanced fetal echo analysis where when we suspect certain diseases like these, then the thicknesses become very important. But this comes really at the fag end of learning fetal echo. And these diseases are quite rare.
Thank you. Next, what is the ideal position to perform fetal echo?
Wait for apex to point up. Dorso-posterior, apex pointing up is the ideal position.
Thank you. Do we get false positives in the third trimester fetal echo, sir?
Definitely yes, because we will not be having the right view. One small thing I will share with you. The 3-vessel tracheal view, which is a V confluence, in the third trimester becomes opened out and a U confluence. So things like this will baffle you because as the heart enlarges and the vessels become more tortuous, it may look like a right-sided aortic. This is one small example because you said what are the possibilities of pitfalls and misdiagnosis. So a simple example is the sharp 3-vessel view becomes a U type of 3-vessel tracheal view. So never try to diagnose something new if you're not sure. You're not really expected to pick up something in the third trimester. Though it is difficult to tell that strictly, you are supposed to, in the court of law, you're supposed to pick up everything, but it is going to be difficult. You will be lucky if the dorsum vertebra is posterior, then the heart can be very beautifully seen in the third trimester.
Thank you. So the last question is isolated large aorta in TVV, but LV is normal. How to proceed, sir?
Okay, LV normal, isolated large aorta. Look, think of aortic stenosis, post-stenotic dilatation. So take the velocity properly and see whether there is a aortic stenosis. And syndromes like Williams syndrome has aortic stenosis, and look for those.
Thank you. One more, how to rule out any ductal constriction?
Not at all difficult. 3-vessel tracheal view and 3-vessel view have the descending order in size of pulmonary artery, aorta, and SVC. So in a ductal constriction, first of all, in your 3-vessel view, the P, instead of being the largest vessel, may not be large enough. It may be slightly small. Second is, in the 3-vessel tracheal view, the duct itself may be narrow. The most important is, once you realize this, you do a velocity, then you will have either you will have in a significant constriction, you will have a high velocity jet. And if this has been going on for some time, you may be having a tricuspid regurgitation also. You may be showing right ventricular size abnormalities also.
Thank you. So the very last two more questions added. Ideal time for fetal echo, sir, to counsel patients. And the next is how to view the number of cusps in the valves.
Fetal echo actually starts from 13 weeks. That's why there are dedicated talks on 13-week fetal echo. So I would say ideal time to start fetal echo is 13 week. But practically 18 weeks, we can do a good fetal echo and repeat it by 22 to 24 weeks for counseling in order to see whether termination has to be offered before 24 weeks. Viewing the cusps of valves is a little difficult thing. In your long axis, we see only two valves, we see only two leaflets. But there is something called as the RVOT short axis view or the circle and sandwich view, where we will get the aortic valve in cross section, where we will be able to see the Mercedes-Benz sign, where we will be able to diagnose and differentiate tricuspid aortic valve from bicuspid aortic valve.
Thank you so much. That was wonderful, awesome. And we answered so many questions and so beautifully and so patiently. Thank you so much, sir.
Thank you very much.
Thank you so much. So over to you, Pooja. Thanks.
Thank you so much, sir, for your insights were very invaluable and greatly appreciated. We are truly fortunate to have you as a speaker. Thank you once again for your time and knowledge. We look forward to hear you once again in future. Thank you so much, sir.
Hope to see all of you during the courses. Thank you.
Thank you so much. Thank you so much.